open the floor to Q&A. After that, any press who are in the room can do individual one-on-one interviews as they wish. So that's kind of the format today. Welcome. My name is Mitch Overton. I'm from the University of Iowa College of Public Health and Communications Office. We appreciate you being here today for the release of the 2023 Cancer in Iowa report. We certainly appreciate the opportunity to talk with you all about this and to share the story. So to start things off, I'm going to turn things over to Dr. Mary Charlton.
Thank you, and thanks everyone for being here today. Each year, the Iowa Cancer Registry releases a report projecting the numbers of new cancer cases and cancer deaths among Iowans based on our registry data, as well as on death certificate data provided by our partners at the Iowa Department of Health and Human Services. This year, we celebrate our 50th anniversary and have therefore focused this year's report on trends in cancer since 1973. But first, I would like to start off by focusing on our projections for 2023. We estimate there will be 20,800 new cancers diagnosed among Iowans this year, an increase of 800 from last year, and double what we registered back in the 1970s. Breast, prostate, lung, and colorectal cancers continue to make up almost half of all cancer cases in Iowa. We estimate there will be approximately 6,200 cancer deaths among Iowans in 2023. This is a decrease of 100 from last year, and interestingly, about the similar number of deaths that we registered back in the 1970s. Lung cancer continues to be the most common cause of cancer deaths, accounting for nearly 1 out of every 4 cancer deaths in Iowa. Colorectal cancer is the second most common cause of cancer deaths, and pancreatic cancer is the third. The report also includes estimates of the numbers of cancer survivors in Iowa. We estimate there are almost 165,000 Iowans who have been diagnosed with cancer at some point since 1973 when the registry began collecting data. This year, the report focuses on cancer trends over the past 50 years and highlights successes and opportunities to reduce the burden of cancer through prevention and control efforts. Beginning with successes, cancer mortality has decreased over time due to decreased smoking, increased cancer screening, and advances in treatment. As highlighted in the timeline in the report, the 2007 increase to the Iowa state cigarette tax from 36 cents to $1.36 had a substantial impact in decreasing cancer mortality in Iowa. Lung cancer screening is now widely available across Iowa for people ages 50 to 80 years with a 20-pack year or greater smoking history. Studies indicate detecting lung cancer at earlier stages can lead to improved survival. 5-year survival rates have also significantly improved among those diagnosed with cancer. Less than 75% of people diagnosed with invasive breast and prostate cancer survived at least 5 years back in the 70s, but now over 90% survive at least 5 years. Improvement in breast cancer survival is attributable to screening with mammograms to detect cancer at an earlier stage, as well as advances in treatment. Improvements in prostate cancer survival is largely due to improvements in treatment. Less than half of people diagnosed with invasive colorectal cancer survived at least 5 years back in the 70s, and now over 2/3 survive at least 5 years. This is attributable to screening options, including colonoscopy, that detect the cancer earlier when it is more easily treated. The rate of new cases of colorectal cancer has been decreasing since the 1980s, largely due to the removal of precancerous polyps during colonoscopies. 5-year survival has also improved for many of Iowa's other top 10 sites, including thyroid, melanoma, oral cavity and pharynx, kidney, non-Hodgkin lymphoma, leukemia, and pancreatic cancers, although survival from pancreatic cancers remains very poor. Now for some areas that need to be targeted for improvement. Iowa has the second highest overall cancer incidence in the US, behind only Kentucky. Iowa is the only state with a significant increase in cancer incidence from 2015 to 2019, which are the most recent years for which data from all 50 states are available. Iowa ranks #1 among all 50 states for rates of new cases of oral cavity and pharyngeal cancer, also known as head and neck cancer. These can be prevented through reduction in tobacco and alcohol, and through use of the HPV vaccine, since almost 1/3 of these types of cancer cases are caused by the HPV virus. Iowa is also in the top 5 for leukemia and melanoma. Unfortunately, we do not yet know how to prevent leukemia, but we do know that you can significantly reduce your risk of melanoma by reducing sun exposure, using sunscreen, and avoiding tanning beds. Finally, Iowa has the second highest cancer incidence rate and third highest cancer mortality rate among our Black population. Iowa also has one of the greatest differences between the rate of cancer deaths between Black and white people of all 50 states. Addressing these inequities, particularly in prostate, breast, and uterine cancers, is critically important and warrants further research and public health initiatives. The identification of these trends, successes, and opportunities for improvement are made possible by the data that is painstakingly collected by the Iowa Cancer Registry and our hospital registry partners across the state. Today, we have gathered a panel that includes Dr. George Weiner, Director of the Holding Comprehensive Cancer Center, Dr. Ingrid Lizarraga, a breast surgeon at the University of Iowa Hospitals and Clinics, and the State Chair for Iowa's Commission on Cancer Accredited Hospitals, and Diane Anderson, a breast cancer survivor who is instrumental in prompting a recent cancer cluster investigation using Iowa Cancer Registry data. They will talk about how data from the registry has helped them in their roles.
Well, thank you, Dr. Charlton. As Mary said, my name is George Weiner, and I have the honor of serving as the Director of the Holding Comprehensive Cancer Center here at the University of Iowa. Our cancer center is dedicated to reducing the burden of cancer for Iowans and beyond through the mutually supportive missions of research, clinical care, education, and community outreach. Now, when thinking about cancer research, the tendency is to think about researchers looking at genes and cells in the laboratory, or perhaps clinical trials where new treatments are being evaluated. Equally important is research into understanding the burden of cancer in the community and to understanding how we can take the advances we've already made and make sure everybody can benefit from them. Mary already mentioned HPV. Well, through basic research, we understand how the HPV virus gets into cells, how over many years it can make those cells become cancerous. And we have ways of detecting whether the cells have been caused by an HPV infection. We developed a vaccine that's extraordinarily safe and extraordinarily effective if given before the HPV infection takes place, when people are younger. What we haven't done as well as we'd like is been able to get that vaccine taken up by all the communities that really need it. And that's where data, such as the data from the registry, really comes in. It can help us identify what we're doing well, what we're not doing well. And that allows us to direct our resources to where they're really needed so that we can take the advances that we've made in our research laboratories and our clinics and make sure everybody can benefit from it. So the research that is based on the registry is just as important as research in the test tube or in the clinic. It's really where the rubber meets the road, and we're able to take our advances and help and make sure everybody can benefit from them over time. As Mary said, we've done well in some areas. We have not done well in others. And the registry really has served as the foundation for our ability to decide how we use our resources to benefit the people of Iowa.
First off, thank you, Dr. Charlton, for everything that you do. So I'm Ingrid Lizarraga, and I'm a breast surgeon at the University of Iowa. I'm also a health outcomes researcher, and I sit on the steering committees for the Holding Comprehensive Cancer Center and the Breast Center. I also serve as the Commission on Cancer State Chair for Iowa, which means that I provide support to hospitals across the state that have demonstrated a commitment to high quality cancer care by seeking accreditation, quality accreditation for their cancer programs. I would say that the cancer registry data really is important to me in all of those roles. So as a breast surgeon, it's really useful to know what the cancer burden is in the state. I think it's very heartening to see that the survival for breast cancer is over 90% in Iowa. But it is still, breast cancer is still the one of the top 5 sites that cause cancer death in Iowa. And as Dr. Charlton pointed out, the rate of breast cancer is rising a little bit in the state. So I want to encourage women to continue to get their mammograms, because we do know that survival is tied to early diagnosis, and that's one way to get an early diagnosis is to get your mammograms. In my roles in the Cancer Center and as state chair, the information from the registry helps us to understand the trends, as Dr. Weiner said. So things like, that really scary rate of oropharyngeal cancer that's risen, melanoma, leukemia, and then the differences in outcome by race that Dr. Charlton talked about. It helps us to understand how best to focus our resources for things like strategies to increase HPV vaccination rates, and also investment in things like patient navigation and financial counseling that can increase access to care for everybody. And then finally, as a researcher, the registry is really invaluable for understanding the patterns of care across the state. So I'm particularly interested in rural cancer care, and we've been able to use the registry to identify some gaps in the care that some rural patients are receiving. The nice thing about the registry is that it doesn't just tell us who's getting cancer where, but it also tells us whether or not they're receiving appropriate and timely treatment and what the outcome of that treatment is. Dr. Charlton and I are involved in a National Cancer Institute funded research project that seeks to leverage the resources of the University of Iowa and Holden to support high quality cancer care in rural hospitals that are taking care of many of our rural patients. We're actually able to provide a hospital's own data with them so that can help them evaluate and improve their quality of cancer care. And that is a tremendously powerful tool. I think we're really lucky to have such a robust, high quality registry in our state. Thank you.
I'm Diane Anderson. I'm from Cedar Falls. I'm a retired teacher from Hudson Community Schools. In September 2020, I was diagnosed with triple negative metaplastic breast cancer after discovering a small lump on my arm. I have no history of breast cancer in my family, and I've never missed my annual mammograms since the age of 35. Since this was a very aggressive and fast-growing cancer, my treatment started immediately. I went through 5 months of chemo infusions, surgery to remove the tumor, which did not respond to the chemo, and 25 rounds of radiation, and then 6 months of oral chemo. April 1st of this year, I will be cancer-free for 2 years, since my tumor was removed with clear margins and no spread to lymph nodes. I have a blood panel every 3 months, and my MRI and mammogram every 6 months for the next 5 years. This has been the toughest 2 years of my life, but I've learned a lot from it. Cancer doesn't discriminate. It can attack anyone. It got me. I've become a prisoner of fear, but I'm trying hard to overcome that with gratitude, strength, and hope. Otherwise, I can't live the life that I fought so hard to save. Cancer doesn't have to be a death sentence, but it is a life sentence. I will forever be on guard. In August of 2022, I became aware of yet another teacher from Hudson Community Schools, the district I taught in for 34 years, diagnosed with breast cancer, which now brought the number up to 12 of us in 10 years. Actually, there are 13 of us, because after this went on the media and viral, another teacher who had moved from the district also came forward. I felt this was an alarming number for such a small district. So I called the county health department and explained the situation. They referred me to the state health department, who then put me in touch with Dr. Michelle West at the University of Iowa Cancer Registry, who was wonderful. After providing her with the information I had, she worked continuously, guiding me on the next steps to begin a cancer cluster investigation with the University of Iowa. During the almost 4 months of very intense work and research by the University of Iowa team, I always received weekly updates, and my numerous questions and concerns were always addressed immediately. In the final report, a cluster was not determined, but one could not be ruled out. I cannot praise this team of researchers enough. This has helped raise awareness and encourage proactivity with all types of cancer. Their work has proven to be so important within our cancer community, which I'm now a part of. Cancer is becoming much too common, and we need to put the brakes on it. My plan is to continue gathering information and listening to concerns from the citizens of Hudson, and hopefully be able to provide the investigators more data so they can continue looking into the cancer situation, not only in the school, but in the community that supported me as a teacher for 34 years.
Thank you. We'll go ahead and open up the floor to questions. If you have one, feel free to ask any of our panelists here.
We're so good, we answered all the
That's right.
questions.
Everybody's thinking.
Well, I might just make one comment that, you know, the report includes numbers. But obviously, each number there is a life and the life of loved ones. And we recognize that the numbers are a tool. But the real importance of this is the impact they can have on people's lives. And so we don't want to look at the report as just numbers.
Well, I just wanted to confirm something. So you said Iowa has the second highest incident rate of cancer. Did you say it was the only one that was going up, or are there others going up?
No, that's correct. We're the only state in which the average annual increase is rising over the 2015 to 2019 period in a statistically significant way.
Yeah. And I see some things listed here, but can you guys know what is behind that at all?
Yeah, we've really been seeing. Thank you. Yeah, thank you for that question. We've really been trying to dig into that because it just seems so unbelievable that, you know, here in Iowa, we would have the second highest rate of new cancer cases in the country. You know, it's not unexpected that Kentucky would have the highest rate. They're right in the tobacco belt. There's a very high smoking rate. We don't have as high a smoking rate. We don't have as high as lung cancer rate. But what we do have is a relatively high rate of just about every major cancer type, kind of across the board. You know, a lot of that is tied to, you know, alcohol exposure, even though it's not as tightly linked to cancer as smoking. We have a lot of exposure to it in the state. So that's one thing. You know, we continue to kind of drill into it, but there's not just one kind of, it seems like a mountain of pebbles. There's not just one silver bullet that explains why we're so high, but we've been trending this way for a long time in our ranks. So I think it's really time to turn it around and get back to average.
You have seen some successes over the years, though, too, in like decreases of rates of smoking, leading to some decreases as well. Maybe talk about some of those successes you've had.
Yeah, I think we have seen, you know, again, I mentioned the raising of the tobacco tax really made a big decrease in our smoking rate. And then we see it in our rates of lung cancer and lung cancer deaths. So that's been huge. You know, I think we've done a good job of getting people back to screening and having relatively high screening rates in the state. So that's great. I do think we're detecting the cancers early. And that could explain why, you know, in 1973 and now we count the same number of cancer deaths at each time. But now we're reporting double the number of new cases in 2023 that we were in 1973. So same number of deaths, double the rate of cases. So the bad news is, yes, we are high in cancer, but the good news is people aren't dying from it nearly as much as they used to. We're keeping that number of deaths stable.
And how does Iowa compare in terms of its survival rate increases with the rest of the country? Is everybody seeing that?
Yeah, we're on par with most of the other registries that we've looked at, and definitely we do well. We do average, if not a little bit better. But where we see our trends really falling off is incidents, where people are starting to really level off and starting to decline. Even in our surrounding states, every state that touches us, nobody has as high of an incidence rate that we do. And their rates are leveling off while ours are going up. So we just can't really figure out what is it about Iowa, what is it about our population why the new cases are going up so much more than in other registries, other states.
I might just comment on a partner of the registry and the Cancer Center, which is the Iowa Cancer Consortium, which is the statewide organization that's really charged with identifying best practices in cancer control and working to help individual communities adopt those policies and those approaches. And Mary is currently the president of the Iowa Cancer Consortium. So that really helps us take the knowledge that's gained from the registry and move it as quickly as possible to evidence-based approaches to cancer screening and prevention, HPV vaccines, et cetera.
I do just have one more start. Are you guys looking to do anything different with the registry? In terms of like what you're gonna be collecting or?
Yeah, we're always being asked to sort of collect more and more, and in the era of precision medicine, where if this mutation, then do this, or if this subtype of breast cancer, then do this. So as science really evolves and there's more markers for different types of cancer, we are being sort of pushed to capture those. And so we're able to do that a lot through something called electronic pathology reporting. And so we really work with our hospital partners around the state to get that. And they can send us basically a diagnosis of cancer as soon as they call it. And we can get a lot of that information from there. We're also looking at ways to collect things like sexual orientation and gender identity. Those are not variables that are collected right now, but we know that population is at risk for worse outcomes for the gender minorities. So we are looking to figure out ways to collect things like that. So we're always looking to figure out how to collect more with our current staff, and a lot of that we can gain through some efficiencies of collecting electronic data that's becoming increasingly available, and really working with our partners at the Department of Iowa Health Services and things like the state's health information exchange to be able to do that more efficiently.
With the information that you presented today and in the report, are there specific things, knowing what you know as cancer experts, are there specific things that you wish Iowa policymakers might take special note of?
Well, I'll start. I think one we've talked about a couple times already, and that is the HPV vaccine. It's incredibly effective. It is incredibly safe, and it's an anti-cancer vaccine. And we just think the message needs to continually be put out there that it's important for adolescents to get the vaccine so they don't develop these various cancers when they get older. So that's one message I think we always want to continue to repeat.
I would say just on a more general level, the Iowa Cancer Registry, not every state has a registry like the Iowa Cancer Registry. We're a SEER state, our registry is extremely high quality. So we're really lucky, like we have all this data, hard facts that tell us what cancers, threaten our population. So that to me is a no-brainer that information should be used to direct policy for things like HPV vaccination and sunscreen and that sort of thing. So it's just sort of a general philosophy of using that information to inform our strategies. I did want to say something that Mary did not give herself credit for, is that, so I mentioned that I was a Commission on Cancer state chair, and I help hospitals in the state that are accredited. And one big tenet of that is that these hospitals have their own registries, because what they have to do is use their own data to continuously assess their quality of care. But that can be a real struggle for smaller hospitals, especially rural hospitals. And so Dr. Charlton really is the first in the country who has developed an infrastructure to help these hospitals to collect data that can then be fed back to them. And that is, I think, pretty cool.
We have a lot of, and kind of, how are they doing?
We do have a lot of rural hospitals, yes. I would say the majority of them. Yeah, I would, we have, I think 84 critical access hospitals, which are by definition rural. And then we have another set of hospitals that are sort of in between that size but yet smaller than the bigger cancer centers. And so we've really been partnering with them that they treat a lot of our rural cancer patients and they're doing a lot with really limited resources. So we try to partner with them and as Dr. Lizarraga said, provide them with data, provide them with some expertise and resources from the University of Iowa. Because, it's the mission of the Holden Comprehensive Cancer Center to really help the entire population of Iowa, not just the people who walk through our door. And we need to be providing patients and providers and communities with the information and resources they need to reduce the burden of cancer in their communities and provide really high quality of care to their patients so that they don't have to drive over to Iowa City or to Des Moines or up to Mayo. They can stay close to home and get really good care.
And so when did you create that infrastructure to help the more rural hospitals collect data?
It's just been within the last 2 years, we've been really focusing on that.
Okay.
We have some partners in St. Anthony's in Carroll, Spencer Hospital, Mercy in Clinton, and Great River, changed names.
Southeast region.
Southeast Iowa Regional Hospital in Burlington.
Anybody else with questions?
Not to ask you to speculate too much, but do you have any leads in the mystery of the increased Iowa cancer rates? Obviously, we don't know for sure, but what are, I'm sure someone is investigating this. What are they investigating? What are they postulating about?
Well, we kind of try to look at, the risk factors, but it's really difficult to do in cancer because your risk factors happened decades ago sometimes, and the cancer is just manifesting now. So we are working with some of our partners at Iowa Health and Human Services to really look back as far as the behavioral risk factor surveillance system goes, to look at some trends in that, really figure out where we're at compared to other states, is our risk factors different. And I think the report does a nice job of highlighting, we do have, again, alcohol exposure. It's not that tightly linked to cancer. We don't know that alcohol in and of itself causes cancer, but we certainly know it contributes to it. We know that here in Iowa, we have very broad exposure. So while, smoking very tightly linked to lung cancer, we know it accounts for 90% of lung cancers. That's about, somewhere in the realm of 15 to 18% of the population that are smoking. You can imagine the percent of the population in Iowa who drinks and has exposure to alcohol. And that's nearly all adults in some way, shape, or form. So I do think, that might be a sneak peek for our future report will be on alcohol related cancers and exposures. So I think that's one. Really physical inactivity is another issue we have in Iowa. Just moving. I'm not saying like sweating it out and, exercising and powerlifting. I'm saying just moving and being active is so important in preventing cancer. And we tend to rank pretty low on the percent of Iowans who are meeting physical activity requirements. Just eating healthy diets. We're like the breadbasket of the world. And so it would be great if people were eating more fruits and vegetables. Those are really helpful in preventing cancer. So, it's not like I said, there's no smoking gun or something really exciting that we can do. I think it's just a lot of things collectively that we need to do as a population. We have the data. We take care of each other in Iowa. We have strong communities. We have strong programs and organizations. I know we can do it. It's just a matter of really figuring out how to motivate people and organizations and make policies that are really going to make it easier for people to do those things.
I was just wondering, these are obviously like the personal behavior stuff is important. And I wondered if you guys are looking into environmental factors as well, like whether there's something with harming chemicals or whatever.
Yeah, that does come up a lot. And that's where I really wanted to focus on how we compared to all the states that touch us that would have similar agricultural exposures. And we still see Iowa as very different from those surrounding states. But there's always, we hear a lot of concerns about our water, about forever chemicals floating down the Mississippi River, pesticide exposure, we know, in some cases is linked to certain type of blood cancers. So those investigations are ongoing, and that's really where cancer cluster investigations come in, like Diane mentioned, because we're always trying to stay on top of really investigating if somebody thinks that there's a certain kind of type of cancer or a certain exposure in their area that we need to look into. And that's where Dr. West and Dr. Nash from the registry lead those investigations to kind of stay on top of that. It's just that because the numbers are often quite small, it's very hard for us to prove that there's anything there, but we certainly monitor that. And those are, you know, when we see things like that, we're so high in leukemia, that does make you wonder about some environmental exposures in our state.
So you had said that this is the 50th year for the Iowa Cancer Registry, and I wondered, do we have 50 years of data for all the other states?
We do not. That's kind of one of the reasons I think Dr. Lizarraga was saying we're so lucky here. Our registry is funded by the National Cancer Institute, who started this registry program back in 1973, and we were one of the original 9 registries at that time. Other registries have since came online over the years, but we're really one of 9 that has data, really high quality data back to 1970.
Could that explain some of the differences in incidents that we have longer data, we have better data?
You know, we've kind of thought of that. I think you brought that. Are we just really good at finding it here because we have such a strong registry? I think that's certainly a contributor, maybe that we do really intensively look and make sure that we're registering all cases of cancer. But the other SEER registries are held to the same standards that we are. And so when I compare us to those other registries, we still look different in our incidents. And in other registries that are newer, you would think that their trends would be getting, if that was the driving factor, you'd think that their trends of new cases would be going up because they're getting better each year at finding them. And we're not seeing that. I don't think it explains it, but I think we are good at it.
Yeah, Mary, I'll ask a question. Is that data you're talking about adjusted for age? Because obviously cancer is more common as we get older.
Right, yeah, all the graphs and figures in the report are age adjusted because we do know in Iowa, we do have an older population than most other states. So we certainly expect to have higher numbers of cancers, which is why in the report, and a lot of what we put out, we focus on age adjusted rates. So kind of applying those rates to a standard population across the US, we still have really, really high rates of cancer even after accounting for age. Thank you for pointing.
We have pretty high rates of mammography in the state. Could that account for breast cancer? Is our mammography rate going up maybe?
So we do have, I think we're maybe ranked 8th highest in the country for our mammography rate, which is great, but we don't see changes to that rate because we're already high. We don't see big increases to that really match the increases we're seeing in breast cancer. So while some of that may be a contributor that we're really good at finding breast cancer, it doesn't really explain differences because we're not seeing differences in our rates of mammograms. Thankfully, we're pretty high over the last several years. And hopefully we continue to be high. I mean, that's just one last thing I would like to point out is people really need to get back to screening after the pandemic. Those screening rates went way down during that time, and through no fault of anybody that you couldn't even get into your doctor, and sometimes they weren't offering those types of services. But it's time to get back into screening and find those cancers early when they're more treatable.
Okay. Thanks very much, everyone. I think we'll conclude things here today. And if there are any members of the media who want to do individual interviews with our panelists, feel free to do so. You can do them here in the room. We've got lots of space around here if you want to go outside this room as well. So great. Thanks very much, everyone.
Let me